Good afternoon and welcome in once again to Evergreen Talks, a monthly Facebook Live event where the physicians, providers, and specialists of Evergreen Family Medicine and Women's Health and Urgent Care present topics that matter to you. Evergreen Talks takes place on the second Thursday of every month at 4 o'clock on Facebook and on YouTube. Today we have Dr. Natalie Moffett with us, who's going to talk about heart failure, and we're going to learn some things from her today. We are live on the internet and the interwebs, and that means that you have the opportunity to ask questions as we go through the presentation today. If you have a question for Dr. Moffett, just write it in the chat, and at the end we'll have a Q&A and chat about some of the things that we learned today from Dr. Moffett. So with that, Natalie, take it away.
Perfect. Thank you. Well, the first thing that I wanted to talk about today was basically just what is heart failure. It is a term that I'm sure many people are familiar with because it is unfortunately a condition that many people have. I think the latest estimate I saw was somewhere in the 6 million category of number of people in the United States with some form of heart failure. And actually that is considered to be a significant underestimate because it is not something that we have universal screening for. So without further ado, I was going to talk today about this very common condition, what exactly it is, and hopefully give a little bit more insight into what your doctor or primary or PCP is doing to try and treat it for you. So on the next slide, we'll see kind of some disclosures. I'm an employee of Evergreen Family Medicine, and I have nothing else to disclose. I'm not an employee of any other pharmaceutical company. These are a couple of references I used. I have several illustrations in this presentation, and I tried to use the actual site that I pulled the illustration from as best I could into the slide. So if you have any questions about any of that, just ask me. As far as what I'm going to try and accomplish with this talk, I've got a couple of goals listed. The first thing is just going to be to define the terms of what exactly congestive heart failure is. We try to name things in medicine as obscurely as possible. This is no exception. And then to try and tell everybody sort of how a person comes about getting congestive heart failure, and then what we do to sort of treat it, and whether or not it's going to be something that is going to end your life, which is always one of the first questions people ask me when I tell them that they have something like congestive heart failure. So next, as far as defining what it is, okay. So on the next slide here, we've got a picture of a normal looking heart, okay? So unfortunately, the heart does not look the way we all learned to draw it in kindergarten with its beautiful heart shape. It actually is closer in size to the size of your fist, and it sits in your chest a little bit left of center. And it has all of these really big blood vessels coming off of it. These are actually referred to as the great vessels. The blood flow comes into the heart in the right atrium, and then it flows from the right atrium into the right ventricle. And from the right ventricle, it actually leaves the heart again. It goes into the lungs, and in the lungs, it picks up oxygen and it drops off carbon dioxide. And then it returns, it does a little loop-de-loop, comes up right on back, just a little U-turn, comes back into the heart from the pulmonary vein, enters into the left atria, and then comes down through the mitral valve into the left ventricle. The left ventricle is very important. This does the vast majority of the pumping of the blood to the rest of the body. This is the part of the heart that has the most musculature, and it's one of the largest chambers, hopefully, in your heart. So it enters into the left ventricle, and then it is shot out through the aorta. The aorta is the largest blood vessel in the body. It has several big offshoots. One goes to your arm, one goes to your other arm, and then one goes up to your brain. And then it curves down into the abdominal aorta, and it distributes to the rest of the body. So if this process is working properly, you're going to see the top of the heart beat and the bottom of the heart beat soon afterwards. So it's a beat beat. That's just where your lub-dub comes from. Lub-dub, lub-dub, lub-dub. Okay. As a general rule, the healthy heart is going to carry the oxygen-rich blood from the lungs to all the little cells of your body. They are going to go from the heart into arteries, and then they're going to distribute their oxygen through capillaries, and then they're going to be shunted back into veins, and the veins will carry them back to the heart. So next slide. So this is pretty important when it comes to understanding congestive heart failure, because in congestive heart failure, if you've ever been around anybody with CHF, you will know that fluid is a thing that we talk about a lot. We're always talking about, oh, what's your swelling like? What's your fluid like? And the reason why we talk about that is this particular phenomenon right here. We have to learn a little bit of physics to be able to understand exactly what's going on here. So as the blood flows through the blood vessels, there's a lot of different forces that are carrying that blood in one direction or another. The heart is generating the flow through the capillary bed that's referred to as the blood flow. However, there's also forces that are pushing it outwards through the blood vessels and inwards back into the blood vessels. The capillaries are designed to be kind of porous. So for anybody who does any gardening, think about your soaker hoses. Okay, so it's like a canvas hose. They're containing most of the fluid, but when there's enough pressure, it's going to leak out the sides. The pressure that's leaking out the sides is called the hydrostatic pressure, and it's the pressure that the blood flow generates against the walls of the capillary. This is really important. This is how your body carries blood to all of the little cells that it's passing through. But if all of our blood left, if all of that fluid left through the capillaries, we would never have any blood to pump anymore. We would lose all of our blood in our legs and in our hands and in our brains. So there has to be a force that's bringing that fluid back into the capillary bed. That pressure is called the oncotic pressure. And that's a osmotic force that is generated by the protein that is in your blood and the red blood cells themselves. When you have enough red blood cells and you have the right amount of protein in there, that pressure should match pretty closely the pressure outwards. You can see in my illustration there, at the beginning of the capillary, you should be able to force that fluid out so that everybody gets the oxygen they need. And then by the time you get to the bottom of the capillary, once the pressure from the heart has kind of dropped off, you should be able to get some flow back inwards. Okay, that's the way a normal capillary works. If there's anything that throws off that balance, for instance, that person doesn't have as many red blood cells as they should. Maybe their protein levels are low. Maybe for some reason their capillaries are more leaky than they should be. Or, the most pertinent to our discussion, perhaps the pressure in the blood vessels is lower than it should be. If that's the case, this delicate balance is going to be messed up. Okay, so if we look at the next slide, we'll see kind of some stuff that happens. So heart failure is when this all goes wrong. Okay. So in heart failure, we have two main categories. I'm just for future reference, if anybody who's trying to nitpick here, we're going to talk mostly about left-sided heart failure today. There's two main categories of left-sided heart failure. The first is called reduced ejection fraction. This is the classic form of heart failure. What has happened with reduced ejection fraction heart failure is, for whatever reason, that left ventricle, the thing that was really strong and is supposed to be generating most of the force to be able to get the blood out through the body and keep that pressure nice and high through the capillaries so that the fluid stays where it's supposed to, that left ventricle is weak. There's many different reasons why this might have happened, and we're going to go through some of those later on. I want you to have a look, though, at this picture of the heart and notice the differences from what I showed you earlier. That left ventricle is dilated. It is bigger than it should be. It can't generate the force the way that it used to. It's a very weak squeeze to it for whatever reason. Unfortunately, this means that the pressure coming out of the heart is going to be less than ideal. And the fluid is going to try and settle because it doesn't have the verve. It doesn't have that push to get it all the way through those blood vessels. So especially in the areas that are the furthest from the heart, so the legs, the hands, these areas are going to have low pressure in their capillary beds, and they're going to leak. And they're going to leak in such a way that they cannot pull the fluid back in time to get it back up to the heart. And that's where we start to see some of that fluid start to settle. So on the next slide, we're going to talk about the other form of heart failure. This is called preserved ejection fraction. You'll sometimes see us refer to these as or hear us say them as HFpEF or HFrEF, which are just fun words to say. The preserved ejection fraction heart failure, this is not a problem of a weak heart muscle. This is a problem of a stiff heart muscle. And again, there's a number of reasons why this might have happened to someone. But in general, this stiff muscle is, again, not able to generate the same amount of force that its healthy counterpart would have been able to do. So the fluid is slow and it's settling. So just like with the previous form, we're going to see swelling in these patients. The organs are not going to be able to get the oxygen delivery that they need. And when this gets bad enough, we're going to start to see some problems with how those organs are functioning. Okay. So on the next slide here, we're going to talk a little bit about what happens to that fluid as it tries to escape the blood vessels. Typically, that fluid is picked up and returned into the circulation by something called the lymphatic system. If anyone is dealing with swelling on their own, they may have heard the term lymphedema. Lymphedema comes from the same roots that the lymphatic system does. This system is designed to be kind of like the trash service. It's going to pick up all of that excess fluid that has come out of the blood vessels, and it's going to return it back up into the heart so that it can all be put back into circulation. If something has happened where this lymphatic system is damaged, an example would be if you had an injury to your leg or something, you had surgery on an arm, you might have damage to the lymphatic system. And the result is you're going to have swelling in that limb because this system that is supposed to collect all that fluid is not working. We also have a problem if the pressure coming out of the blood vessels is not where it's supposed to be. If you're leaking more fluid than the lymphatic system can collect, you're going to have fluid. So you're going to develop edema as a result. Okay, that's the hard stuff. That's the physics stuff of this talk. The next slide, we're going to go over some of the things that you might experience if you are, in fact, a patient having heart failure. The first things that people talk to me about when I first start thinking that there's a heart failure situation is they get tired. You're carrying around fluid in places that you're not supposed to. That makes you tired. Another thing that's really classic for heart failure is something that we call orthopnea, which is basically the $20 word for you can't lie flat. The fluid has decided to settle in places it's not supposed to. One instance is in the lungs. When it settles in the lungs, you have a hard time lying flat. So the thing I'll hear is, doc, I'm needing to use more and more pillows at night. I have to sit up. Gosh, I can't seem to fall asleep in my bed. I have to sleep in my chair. These are all unconscious ways of telling me I can't lie flat anymore because I feel like I'm drowning. Edema is the next thing that people are going to notice. Edema is the medical word for swelling. People will have swelling in their legs typically. I've seen swelling in the arms. I've seen swelling in the belly. I've seen swelling in the genitals. These things, this is where the fluid likes to swell or likes to collect. The next most common thing we're going to hear is shortness of breath. This is especially shortness of breath when you're trying to exercise. And it doesn't even have to be exercise that you would register as exercising. Doc, I went down to pick up my mail. It's only 20 yards from my front lawn, and I was short of breath by the time I got there. It's normal daily tasks that are suddenly using more energy and more oxygen than they did before. So because your body is trying to compensate for this slow blood flow, one of the things that'll also happen is the heart will try and speed up. So sometimes the first symptom I'll see of heart failure is your heart rate is not slowing down. This is because your heart is trying to compensate for that slow blood flow. And sometimes people can do it. Sometimes they're able to beat their heart fast enough that that slow blood flow is not happening, or it's not causing other symptoms. So if that's the case, then sometimes a fast heart rate can also be a sign of heart failure. So all of these things separately, not necessarily heart failure. If you start having more than one, that's time to talk to your doctor. Okay, next slide. So the next question people ask me is, now I understand what heart failure is. How does one get it? Okay. I made you a beautiful diagram. Okay. So the biggest ways that people end up getting heart failure is because of the things that you see here. hypertension, which is high blood pressure, valvular disease, my aortic valve is not working anymore, and then ischemic disease. This is, I had a heart attack, I had a silent heart attack, I'm having angina. Coronary artery disease is all under the category of ischemic disease. So these are our three big ones, is hypertension, valvular disease, and ischemic disease. There is a fourth on there. This is connective tissue disease. These are pretty rare. This would be the category of amyloidosis. These would be some congenital things. Maybe there's a genetic mutation that's causing your heart tissue to not be put together the way it's supposed to, and now it's not beating properly. But the big ones, the big three, hypertension, ischemia, and valvular disease. I put some other contributing factors that will lead you to have those conditions. The biggest ones, diabetes and smoking. These are what we call modifiable risk factors. These are typically things that you are able to control on your own. You're probably not going to be able to control if you happen to have a genetic disease that's making your connective tissue not put together well. If you've got diabetes, that is typically a reversible condition. And all of these things put together can turn into a condition that can cause heart failure. Hypertension is a good one to talk about modifiable risk factors with, because if you've got sleep apnea and you're not treating it, that'll give you hypertension. That hypertension over time can lead to heart failure. You're overweight, you've got obesity, you're having a hard time losing that weight. If you talk to your doctor, maybe we can find ways to help you with that. That can reduce that blood pressure, that can reduce that strain on the heart. You never have to deal with congestive heart failure. Lung disease. The lungs and the heart are so closely linked that when one starts to fail, the other follows. So if we quit smoking, if we take our inhalers the way we're supposed to, if we make sure that we're treating things the best way we're supposed to, sometimes we can prevent all of these things from happening. We do see valvular disease happening because of drug use. Rheumatic fever actually used to be a pretty common reason why people had valvular disease. Thankfully, we don't have as much of that anymore. Some people do still get it. So in all, these are kind of some of the diseases that are more likely to cause heart failure than not. The connective tissue diseases are more likely to cause that heart failure with preserved ejection fraction, and the other three are a little more likely to cause the heart failure with reduced ejection fraction. But people oftentimes have a mix of both. Okay, next slide. So the big question, how do I fix this? You told me about it, but what do I do about it? So I have listed out here in probably more detail than anybody ever wanted to know the main classes of medications that we use to treat heart failure. These things are really broken down. When it comes to heart failure medicines, it's really broken down into two major categories. Which things are going to help me live longer and which things are going to help me feel better? These are the things that are going to help you live longer. We have a couple of categories of medications: the beta blockers, what we call the ACE inhibitors, and the ARBs, the mineralocorticoid receptor antagonists, and then what we call the ARNI family, and the SGLT2 inhibitors. So on the next slides, I'm going to explain a little bit more about what each of those things do. Okay, so this chart I think is beautiful. This is an absolutely excellent representation. I think every medical, pre-medical student out there looks at this and starts to sweat because this was test material at least once in your life. This is some of the very detailed information about how all of these medications work. They're all essentially working on different pathways that are involved in helping reduce stress on the heart. So we won't dwell too much on it because it's very technical. If we go to the next slide, we'll start to see simplified diagrams. Essentially, what the angiotensin inhibitors, so this is going to be lisinopril, this is going to be the losartan, this is going to be candesartan, all of these different medications, ramipril, I'm blanking on all of them now, but the ACEs and the ARBs, these medications are going to be considered angiotensin inhibitors. If you look at the simplified diagram, you'll see essentially what happens is these medications cause the blood vessels to relax. So any of those conditions we talked about previously that are causing those blood vessels to get tight and small, these medications cause them to relax. That reduces pressure on the heart, and it reduces the amount of work that the heart has to do to pump that blood back out. So it can be very helpful at keeping the heart healthy. Okay, next. The next medications These are the diuretic medications, okay? So the diuretic medications are responsible for making you feel better, okay? I love this cartoon. I don't know who drew it. I tried to find. I thought it was amazing. This is basically an excellent illustration of what diuretics are doing. They are putting a straw into the areas where the fluid shouldn't be, and they're dumping it back into the heart so that it can be pushed out the kidneys. There are a couple different types of diuretic medication we use. They're sometimes referred to as water pills. I know that's what all of my West Virginia patients knew them as. They will pull the water out of the interstitial fluid, and they will shunt it back into the blood vessels so that the kidney can see it and turn it into urine. People call them water pills because they make you pee. Okay, go ahead. Go next. There are also the SGLT2 inhibitors. This is like the brand new, latest and greatest cutting edge medication that we're starting to use for heart failure. You probably have been inundated with commercials for these medications because the companies that make them are very excited to let everyone know these things are great for your heart failure. So in this category, we have the Flozin medications, okay? So this, by brand name, this is going to be Jardiance, Invokana, Farxiga, and Steglatro. These medications were originally designed for diabetes, and lo and behold, they found out they work really good at keeping the heart happy as well. The way they work is they take the sugar that is in your blood and they make the kidney force it into the urine. Water likes to follow where the chemicals are. It likes to follow where the stuff is. So if you're putting more stuff into the urine, more solute into the urine, the water is going to follow it. So it makes you pee more, and it specifically makes you pee more sugar. So if you're diabetic, you can see how this would be very helpful for you. It brings your blood sugar down by making you pee it out. If you have heart failure, it can be helpful as well because it reduces that pressure, it reduces that strain on the heart. So again, we have a medication that's helping the heart pump better. Okay, next. So these those medications were ones that help to improve the outcomes, and then these ones are ones that are going to help more with your symptom management. So certain diuretics fall into this category and the other category, spironolactone, for instance. But these medications are the ones that you might see being adjusted a little bit more frequently in heart failure patients because it's all about the swelling. We're trying to keep that swelling low so that people can have better symptom improvement. So this is where the Lasix and the Bumex and the torsemide, all these things come in. These are all considered to be diuretics. There are also a few medications that we use to help reduce chest pain when your heart is working too hard. These medications are great. They don't improve your lifespan, but they typically make you feel better. Another one that I added on the end there, oxygen. Some heart failure patients need to be on oxygen. Their body is so stressed out and so strained that their heart cannot pump enough oxygen at the regular room air concentration. You need to be in a really oxygen-rich environment to be able to absorb the right amount. So oxygen can help. Next slide. This is the most important slide, I think, of the whole thing, because we've talked about what heart failure is. We've talked about what causes heart failure. We've talked about the medications your doctor wants to use to treat heart failure. But this is the stuff that, above all else, is going to help this person do well. Lifestyle management is the most important component of congestive heart failure, and it really comes down to about 4 things. Making sure that we restrict the amount of salt you're taking in, the amount of fluid you're taking in, you're taking your medicines, and you're watching your weight. The weight monitoring is a little different than it might have been if you were working on losing weight to look good in your bikini. When it comes to weight monitoring for CHF, what we're looking for is a gauge of how much fluid are you retaining. When we talk about salt restriction, the reason is because when people eat a lot of salty stuff, they tend to want to drink more water. When you drink too much water with heart failure, you're going to hang on to it. Your body is not pushing it to the kidneys the way it should. You're not going to make more pee. You're just going to make more swelling. So we typically restrict people to 2 grams of salt a day and 2 liters of fluid per day. These are the big things that you can do to keep your heart failure under control. Watch your salt. Watch the amount of fluid you're taking in, take your medicines, and make sure that you're watching your weight. We don't want to see more than 1 to 2 pounds in 24 hours gained, and we don't want to see 3 pounds in a week gained. Those are signs to call the doctor and say, hey, I think something's going on. I'm hanging on to a lot of fluid. Okay, next. So the big question, is this going to kill me? Everybody's got heart failure. We talked about how many people got heart failure. What's going to happen to all those people? So I've got some statistics in here about mortality. The interesting thing about heart failure is that the rate of death from heart failure has been increasing since the 90s. So basically more people have been dying from heart failure than they did previously. However, this is likely because the rate of people dying from heart attacks has been coming down. We've been getting much better at treating heart attacks, and as a result, there's more people with damaged hearts out there that live long enough to develop congestive heart failure. So it's not, on the surface, it's kind of a disconcerting statistic. But when you dig into it a little bit, it actually is not necessarily a bad thing. The risk of getting heart failure and dying from it is correlated very strongly to age. If you get it as a younger person in your 60s and your 70s, like that kind of a thing, you're not as likely to die from it as if you've got it for the first time in your 80s and 90s. This is, I could say this about just about any disease, just because you are more likely to die of other things as you get older. Oftentimes we see heart failure associated with other things. Back to that spider diagram that I drew. If you have uncontrolled high blood pressure, if you are smoking, if you have uncontrolled diabetes, all of those things are going to shorten your life anyway. And it's certainly not going to help with heart failure. So if we can control some of those other things, oftentimes your outcome from heart failure gets better. So this statistic is very, very interesting. And this is from a study that was done a while back before we had some of the medications we have today. They have not yet pulled data on it more recently. The life expectancy of a person who is experiencing their very first hospitalization for congestive heart failure is pretty significantly shorter than it should be. If you are stuck in the hospital for the first time with your first episode of acute heart failure, the average life expectancy for a woman would be 1.7 years. If a man is in the hospital for his first episode of acute heart failure, 2.1 years is his average life expectancy. That's not that long. And what it speaks to is the fact that if your heart failure has gotten bad enough that you need to be hospitalized to manage it, odds are we've encountered some irreversible damage at this point. So our job as a primary care office is to try and intervene with people before this happens and try and get them off the track. Okay, next. So there really isn't an outright cure for congestive heart failure. The best thing we can offer is trying to get it, is to try and avoid it in the first place by managing some of those comorbidities, and then to try and keep it stable as soon as you've got it. We want to make sure that we're watching your salt, watching your fluid, you're taking your medicines as prescribed, and you're watching your weight so that we can get kind of an early warning if there's something happening. Okay, next. Biggest thing, please talk to your primary care doctor. If you think you have heart failure, if someone you love has heart failure, if you are worried that you're going to be developing heart failure, please, 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 please talk to your PCP. And hopefully we'll be able to get you on the path to avoiding some of the more serious complications sooner rather than later.
Well, thank you for all of that. Those diagrams are something, and you could have probably spent an extra 10 or 15 minutes on a couple of those, just describing all of the representations that were on there, I would think.
Sure.
As I'm thinking about follow-up questions for you, I'm just thinking about the times in my life when my parents have had heart issues, and how important it is to stay connected with your primary care provider, to stay informed on what's happening and to learn everything you can about what causes congestive heart failure, and then what to do after. And sometimes I think people are a little bit concerned about bothering the doctor, or, is this the sort of thing to talk about? But it sounds like, I mean, that's what you're there for, right?
Absolutely. I mean, there is no bother. I mean, that's what that is exactly what we're here for. We can't help you with a problem that we don't know exists. So if you're starting to have issues with swelling, you're starting to have issues with, not having as much wind as you used to, this would be the time to speak up and say, hey, I don't know what's going on, but something's different. And then, we can start running you down the gambit of trying to find ways to figure out what's going on. We actually can do a pretty decent job with our diagnostics that are non-invasive to be able to figure out if this person has heart failure or not. So what I mean by that is you're not looking at a surgery that we have to do to try and, take a biopsy and see, is this a heart failure heart? No, we have imaging ways of looking at the heart to see if it's starting to develop heart failure or not. Echocardiogram, it's an ultrasound. That's no big deal. So we can figure it out pretty easy if that's what's going on and try and get you right onto the train of, good health.
And then it seems like the consistent message that comes from every Evergreen talk we have is talking about preventative measures. Yeah. It's a lot easier to work hard on not getting some of these big health issues we talk about than it is to have to deal with it after it all hits. And I was glad that you said this slide is the most important slide in here, talking about all of those, the big four things that you mentioned on that slide.
Yeah, that stuff is very important for someone who's already got heart failure. As far as the preventative care stuff goes, it's, we have to control diabetes. We got to get your blood pressure under control. And then like smoking, those would be really the biggest modifiable risk factors as far as trying to reduce the risk that a person has of having a heart attack or a stroke, or a heart attack that might cause the congestive heart failure, a stroke too.
And it may be asking the same question or following up, but here is Sean Webster on Facebook asking this question about compensatory mechanisms involved with CHF. Fancy words here everyone's using. What are the most significant things I can do right now to prevent heart failure? We kind of touched on that just now. I don't know if you want to add anything.
So the biggest things right now would be making sure, like, good diet, good exercise, not picking up smoking if you haven't already, and making sure any diabetes or high blood pressure issues are under control. Making sure you don't start using drugs or something like that would be also a good way to do it.
Terrific. All right. Well, that's what we have for everybody today with Dr. Natalie Moffett. Thank you very much for your information and your presentation today.
Perfect. Thank you, guys.
We can invite people out to Evergreen Talks on the second Thursday of the month. This video is going to live on Facebook and YouTube as well, so share it with your friends and family if you think it will be helpful. And you can visit evergreenfamilymedicine.com for more information. Okay, well, Merry Christmas. Happy holidays to you, Dr. Moffett. Thank you very much.
Thank you. You too, and everyone else.